First of all, I'd just like to thank everybody for inviting us here today. The CCG is very glad about our improved relationship with Healthwatch and how we seem to be working more and more closely together. And I think actually the idea of a critical friend has really been helpful. It's kept that little bit of sand in the relationship and kept us on our toes. So we appreciate that. And I think I would also like to thank particularly Charlie's input. It's been really noticeable, and I've seen how you've kept us on our toes, kept us focused, kept us working, and also been helpful all the way through. So thank you for that, Charlie. In terms of also the report today that we've also seen as a CCG, I'd like to thank all the patients and the participants of that report. So we're looking at that as a CCG. We found it very helpful in terms of the input of actually hearing the patient's voice at the grassroots, and that's been really useful to us. Yeah, that's it. I'm just going to step through though some of the complexity really of primary care now. Someone reminded me of an old television programme, Dr. Finlay, where that was what the world of the GP was like, and we've now sort of changed. We're sort of like doing the work in the community now, and the care of the community we have to provide in terms of primary care is far more complex. So GPs are now often leading on work like diabetes, COPD, heart failure, cardiology, and the care is now in the community rather than just based in the hospital. So what we're seeing now is that change in how people work, and working in such a way that it means that the skills of our GP colleagues are always needing to be updated and improved. What we see here is our Croydon CCG network model. If you see the nice pretty picture there, you'll see that there's actually 6 networks. And that we've done that to help look at the local area and making sure that actually the services that we provide in the local area are trying to be bespoke for the demographics of that local area. But also in terms of the previous things that I was saying, is if I've got an expert in diabetes in primary care, then should that expertise be shared across the neighbouring practices and for those patients as well. So it's trying to work a way of us coordinating the care better in terms of primary care, but also in terms of development of services as well. So if we go for the next slide. Brilliant. So when the white paper came out 4 years ago, we used to have PCTs that were basically managing the whole of the primary care contract and the quality of the contract. To simplify and reduce bureaucracy, where there was one organisation, we decided to produce 2. So that was called NHSE and called CCGs. The CCG was responsible for the commissioning and getting the GP's voice in terms of the commissioning of services, and NHSE was responsible for actually contracting GPs and improving patient care within primary care. Now, slowly over time, we've realised 2 organisations instead of 1 organisation, maybe not such a clever idea. So we're moving slowly back into something called co-commissioning, where we work alongside NHSE as a CCG to improve primary care directly and also reduce the variation between primary care, as well as ensuring that we're getting the right services to patients in things like the acute hospitals and community care. So what do? We help with NHSE manage the Croydon's primary care budget. We ensure patients have equitable access to primary care services, and to try and avoid reading off a list, you can see that there's a fair bit of responsibilities in each one and each turn. And actually the new real one that's coming through at the moment is developing an estates and technology. So your colleague mentioned something called the STP. We're starting to live and breathe that, trying to understand it a bit more, what the actual ask is across South West London. But one of the things that is the case is that primary care hasn't got a good estate. A lot of it's old Victorian houses that were bespoke for the times when Dr. Finlay was walking around. It wasn't necessarily bespoke for the idea of doing minor operations or doing ECGs or even potentially echoes into that accommodation. it wasn't actually bespoke for the idea of potentially having 4 or 5 GPs with different areas of expertise supporting patients in the community. So our estate is a little bit crumbly, and therefore we're needing to put investment into that estate and improve it, and trying to look again back to the network models of actually having focused areas within our different networks to actually support patients and have that coordinated care. So if we go to the next slide. So primary care services in Croydon. So we have 403,000 registered patients. Our smallest practice is 1,713, which is as small as you can really go, to be honest, in terms of a primary care service. We have 214 GPs and 96 nurses. As you can see, we have a high degree of nursing staff within our community, which is great, because it is incredibly difficult to recruit to GPs. So improving nursing staff is fundamental, and making sure that when we see primary care, we see it as a whole team. So we have HCAs that do sterling work, we have our receptionists, and we also have practice managers that sort of keep us going really and telling us what we're actually doing not quite right as a CCG, but also quite often as GPs. I'm sure Ella would testify to that one. We also do a range of enhanced services, so things like how do you do diabetes better over and above what standardly you'd expect, how would you do COPD, and we also support practices, and I think this is crucial, changing the role of the CCG, of changing the variation between practices. So where we're seeing, say, practices needing support, the quality of care isn't quite what we were hoping, we are actually going into those services and helping support them. So again, that's why this report is really, really helpful, because again, what we would like to do in the future is work even closer with Healthwatch to actually know which practices and what practices, so when we go into our targeted interventions, we're getting that direct feedback from patients. Okay, I'll just go on to the next slide. Oh, primary care, there we go. You just went on to it perfectly, well done there. Okay, so what we do is, it's not easy actually. People think that it's really easy to know, what is a good practice, what is a practice that needs support. It isn't actually that simple, because in one area they may be doing really well, like QOF, which is a quality outcomes framework. However, they might be struggling in terms of answering the phone and patients being able to access it. They might be doing really well in terms of the medications they're supplying to their patients, but they might not be doing so well in terms of their referrals to secondary care, doing it at the right time to the right place. So it's actually a complex beast, really. So these are some of the ways that we actually look at it. We use national sources as well as local sources. We'll use things like the Healthwatch report. We'll also look at things like the patient survey. But what we'll also do is then go into the practices with clinical leads, like Agnello, to actually find out what they think that they're doing and how they're doing it. And we'll also use peers to help each other and support each other to get it, start improving and getting it right. Okay, if I go over to the next one. What we have also started to develop in the last year is the GP Collaborative. And some of you might have heard things like called federations. This is a collaborative, is another name for a federation. It's always important in the NHS to change the name of things at least every 2 years, so it keeps you all on your toes. I'm sure Healthwatch used to be LinkedIn, but we've all got that pattern. So what we do here is basically the collaborative is trying to actually work out, as providers, as a group of 57 practices, how they can actually make sure that the care that they give is universally good. So again, supporting the work we're doing with variation is actually trying to say, well, actually, I know about diabetes, maybe you don't. I know about cardiology, and maybe you don't. So some of the care that you're supplying your patients, perhaps I can support you with. So a lot of the work that the collaborative is doing is trying to actually, again, with the CCG, trying to make sure that the universal offer that all the citizens and patients of Croydon get are starting to get the same good quality services. So I'll just go on to the next one. Yeah, this is a lovely complicated slide. as you can tell in the NHS, we do like a good slide with lots of arrows in and lots of boxes. We like a lot of pseudonyms, and we like a lot of names of things that nobody else quite understands, and that makes us look profoundly intelligent. And this is an example of that slide. Okay, so what in the middle of that, you'll see where the number 2 is, something called My Life Plan. Okay, and I think that's a crucial thing that we're trying to actually move forward with. What you'll see in that slide as well is lots of services dotted around. What we're aware of is that quite often for patients with have complex needs or long-term conditions, they'll have something like 6 different care plans. The GP will hold it, one, maybe the nursing care home will hold one, maybe the voluntary sector aged concern will hold one, maybe the community district nurses will hold one, specialist nurses, the CPDs will hold one, and in the end everybody has a really nice plan in their own individual silo, and nobody knows of the other plan, let alone the patient actually having it themselves or the local carer. So one of the things that we're actually striving to through outcomes-based commissioning, and I work with primary care, is to actually have one plan that's shared across providers, but most importantly owned by the patient and by their carers, so they actually know what their plan is and have been involved in that plan. So everybody knows who their social worker is, everybody knows who their mental health worker is, who's working with them in terms of district nursing, what are their SATs are, what are their key medications that they've got as well. So it's very much a way of trying to actually coordinate that care around them. And that's something that the Federation has been heavily involved in, Age Concern have been heavily involved in, Council have been, ourselves as well, and as well as our community provider CHS. And Healthwatch has all the way through kept us on our toes on it as well. Okay, so I'll just go on to the next one. Urgent and extended primary care. So recently, what you may or may not be aware of, we have done a recent procurement process and involvement of patients around actually how we can have our urgent care services better, really. And that's ended up with actually having 4 GP hubs around Croydon that are available for access for urgent care, for those things that you really need to be seen and seen quickly for. And they're now based in Purley, New Addington, one just being defined in East Croydon, and also within the actual current urgent care centre. So that's one of the developments of making sure that patients can actually access primary care services when they have an urgent need. What we're also, though, over time going to be developing services connected potentially to those around 7-day working. So you'll probably hear the government saying that GP services, primary care services, need to be now offering 7-day working 8 till 8. Well, if you can imagine, it's quite difficult potentially for patients to access their GP working predominantly from 8 till 6:30, 5 days a week. If you're not careful, you'll spread that margarine so lightly and so thinly that you may be promising 7 days a week, 8 till 8. However, there's a limited amount of GPs to make that possible. So one of the things that we're doing is making sure that things like the urgent care hubs will potentially work with the appointment systems as well in the future, and therefore we can have more of a shared resource where people can access their own patient records in a different place. Okay, on to the next one. Local, regional, national certificate. Oh my goodness, so I'm not going to go into this into great detail, but if you can imagine, and I'm sure anybody from the members of the council will know that there's always a good idea coming your way, and there's always national evidence and information coming our way. And these are some of the things that are coming our way. But there is a focus, like we've already talked about, in terms of care planning. And like I said, the 8 to 8 GP access. But as we were talking about, we have to be smart, because otherwise the margarine gets spread so thin that the services actually are open, but are they able to see the patients and give the right care for them? So again, it's the idea of looking at hubs and making sure that that access is available for patients, and they've got a high-skilled, high-quality workforce being able to see those patients and also seeing that patient record. Because that's really crucial, because otherwise you're repeating your story every time, and you're also not necessarily knowing all the complex meds that you might be on. Okay, on to the next one. Oh, challenges. Oh, we've got some lovely challenges as a CCG. As you know, population growth is 4%. In Croydon, it's 6%. We're about to potentially grow lots of more buildings, very local to where we are now. We have 9% of primary care nurses are aged 55. Those of us who are fortunate enough to be a nurse in the NHS, we can retire at 55, hurrah. But that does mean there's obviously a whole problem there potentially around the corner. Pressures in general practice have led to fewer training posts being filled and more GPs planning to retire early. You get paid a lot more in Australia. I'm not telling Agnello that, but I think he already knows. There's also 27% of the GP workforce is also over 55. And therefore, what we have done is also compensated by having more nurses proportionately, because of the difficulty to recruit GPs. But obviously, there's a potential retirement issue there, isn't there? So we've got to work that one through. So we have to make Croydon an attractive place to work, and we also have to think on our feet about alternatives. So some of those things are bringing in pharmacists into practices, because pharmacists actually have great clinical skills and actually can help patients with very complex conditions in terms of reviewing their medications. Okay, so I'll just go on to the next slide. Patient access. So just so people know, we do take patient access incredibly important within the CCG and supporting NHSE to start getting it right. In terms of our patient survey, the national survey, which was from 6,113 patients taken this year, to patients that had care in that year, so received care from the GP. 7% of Croydon patients surveyed said it was easy to get through to someone at the surgery on the phone. The national average is 70%. 86% of patients surveyed said the receptionist was helpful. The national average is 87%. And 90% of patients surveyed said their appointment was at a convenient time, and the national average is 92%. Saying that though, there is also a high variation between practices, and that's what I was talking about earlier, about making sure that actually we make targeted interventions in those practices that need support. And that's why we very much welcome the report done by Healthwatch, because I think it does show that variation. You know, if you look at the report, often it will say, my care within the GP has been excellent, however, this bit, my care wasn't so good. So what we need to do is help the practices where the care wasn't so good. Thank you very much.